Hi, everyone. My name is Colleen Flahive, and I will be talking today about milk protein allergy with a specific focus on milk protein induced proctocolitis. So, the objectives today are to define what milk protein allergy is, discuss our current understanding of its etiology, specifically as it relates to milk protein induced proctocolitis and the clinical presentation of such and how we diagnose and manage that. So, first of all, what is milk protein allergy? Milk protein allergy really is an umbrella term that encompasses a spectrum of various disease processes that present with myriad of different clinical manifestations. There is significant overlap with eosinophilic disease, and oftentimes milk protein allergy is a key driver in eosinophilic GI disease. But at its core, it is the body's immunologic response to proteins in cow's milk. The body reacts in different ways to those proteins in cow's milk, and there are both IgE mediated immunologic responses and non IgE mediated immunologic responses. With my focus on milk protein proctocolitis, I'm going to be focusing on these non IgE mediated responses. So I wanted to touch on the spectrum of milk protein allergy diseases and how the different ways that the body can respond to this, to milk protein, and how it can manifest. So there are three kind of big broad categories encompassing how the body reacts and the immune response when it is exposed to milk protein. There are the IgE mediated diseases and responses. There's a mixed category, and then there are non IgE mediated diseases. So for the IgE mediated processes, when the body is exposed to milk protein and there is an allergy, the IgE mediated processes include anaphylaxis, urticaria, and angioedema. For the mixed mediated responses, which is a combination of IgE and non-IgE mediated processes, these include atopic dermatitis, eosinophilic esophagitis, and eosinophilic gastroenteritis. And then for the non-IgE mediated processes, these include milk protein proctocolitis, food protein induced enterocolitis syndrome or FPIES, food protein induced enteropathy, and Heiner syndrome, which is has pulmonary manifestations. And again, I'm going to be focusing on milk protein proctocolitis. So in terms of the underlying etiology for this, in general, for those non-IgE mediated diseases, the mechanism is not entirely well understood. However, for milk protein proctocolitis, there are several hypotheses and theories. And largely, they relate to a dysfunctional epithelial barrier and lining of the GI tract. There is thought that the lining of an infant's GI tract is one, immature, which inherently leads to some dysfunction of its barrier function, or two, that the infant had an acute gastroenteritis, and that illness led to damage of the epithelial lining of the GI tract. And when there is a dysfunctional and impaired epithelial lining, the food that the infant ingests is, it allows for the food antigens, specifically cow milk protein antigens, to be improperly handled, where they normally are broken down. The immune system, because of this dysfunctional epithelial barrier, is able to take the antigen and present it to the immune system whole, which leads to a sensitized immune system. So that when upon repeat exposure to the cow's milk protein, and the body sees this antigen that the immune system has already been sensitized to, it leads to a dysregulated response that is primarily directed at the GI tract and ultimately leads to the colitis. And if you were to look at the if you were to look at it underneath a microscope, you often see patchy eosinophilic infiltration. So in terms of the clinical presentation for milk protein proctocolitis, it is one of the most common causes of rectal bleeding in an infant. It often presents within the first 6 months of life, but often in infants who are less than 2 months old. And parents will often describe other changes in their child's stool, including diarrhea and increased mucus production. The infant is otherwise well appearing in spite of these symptoms. And if an infant is ill appearing, that should alert you to consider more strongly other possible etiologies. And this can also be associated with eczema or atopic dermatitis. So diagnosis is primarily a clinical diagnosis based on the history and exam. However, there can be several workup considerations depending on the situation. A CBC can sometimes be helpful if you're concerned about the degree of bleeding. Most often in milk protein proctocolitis, the hemoglobin is normal to borderline low, and sometimes you can see a peripheral eosinophilia. If you are concerned that the hematochezia is secondary to an infection, you can send stool studies. And if the presentation is confusing or is not entirely clear what's going on, there can be a role for flexible sigmoidoscopy to actually try and get tissue samples to see what it looks like underneath the microscope. And then management, I'll break it down for the management of breastfed infants and for formula-fed infants. For the breastfed infant with milk protein proctocolitis, the treatment is really an elimination diet from that the mother needs to do, where the mother eliminates all dairy products, including all types of mammalian milk, not just cow's milk, but goat's milk and sheep milk as well. There is definitely a role for a dietitian, and for several reasons. One, it can promote better adherence to the diet because it can be tricky to know everything that dairy is in, but then two, to ensure that the mom is getting adequate sources of protein and calcium from non-dairy products. Typically, both with breastfed and formula-fed infants, there should be gross resolution of the blood in the stool within 72 hours. It's pretty quick, but generally it can take up to several weeks, and sometimes an occult blood can even persist longer. But kind of the rule of thumb is if you have had no improvement after 2 weeks, that the mom should then eliminate soy. And again, if there is no improvement after soy elimination, the mom should then eliminate eggs as well. And then for the formula-fed infant, the management is to replace cow's or soy milk with an extensively hydrolyzed formula. There is significant cross-reactivity between the cow's milk protein and soy milk protein. And so the recommendation is not to transition to soy milk, but rather just to go straight to an extensively hydrolyzed formula. Having said that, there are about 5 to 10% of infants who won't respond to an extensively hydrolyzed formula. And at that point, the next step is to switch to an elemental or amino acid based formula. This is a chart that lists the various formula options for the extensively hydrolyzed formulas. In my experience, I've seen most infants on Nutramigen or Alimentum and do very well. And then for the amino acid based formulas, Elecare and Neocate are the two most common that I have seen. And then in terms of reintroduction of cow's milk for these infants, the standard approach is to reintroduce cow's milk at about a year old. However, earlier introduction can be successfully achieved. However, there's just not much in the way of evidence in literature um, to allow for kind of evidence-based reintroduction at earlier ages. For the breastfed infant, essentially the mom will just kind of incrementally increase her exposure to milk protein over several days and monitor for symptoms. And for the formula fed infant, it's a similar approach where there is kind of incremental advancement in the amount of cow's milk mixed in with an extensively hydrolyzed or amino acid based formula that advances every day or every couple days in monitoring for recurrence of symptoms. If symptoms do recur, the infant should go back to either the extensively hydrolyzed formula or the mom should resume the elimination diet and to try again in several months. Overall, this diagnosis carries an excellent prognosis and kids do very well and outgrow it. I did want to briefly discuss a couple other non-IgE manifestations of cow's milk protein allergy. So first of all, FPIES or food protein induced enterocolitis syndrome. These kids, when they are exposed to cow's milk protein, they present sick. There's typically severe vomiting and diarrhea associated with profound dehydration, and they look shocky. Although cow's milk protein is not the only food that can produce FPIES, that and soy are the two most common culprits. And then food protein induced enteropathy occurs when an infant is exposed to a protein that they react to, most commonly cow's milk or soy, that leads to a protracted diarrhea and failure to thrive. This typically presents in infants less than 9 months, and it mimics a post-infectious enteropathy or a slit gut type of picture, and can be confused for that. And then reflux can also be a manifestation of milk protein allergy. And in fact, NASPGHAN guidelines recommend early transition to a partially hydrolyzed formula for reflux if non-pharmacologic methods fail, those being thickening feeds, decreasing volume of feeds, and of the such, for the reason that oftentimes kids improve with removing the milk protein. And with that, I hope you learned something and thank you for taking the time out of your day to listen.